All right. Hi, everyone. Thank you so much for joining me tonight for this pediatric pelvic webinar. So, my name is Sarah. I'm a registered physiotherapist at the Aramosa Physiotherapy Association locations in Elora. I'm also at Guelph Women's Health as well, doing pediatric pelvic. So, for me, I ended up finding my passion in pediatric physiotherapy. Never in a million years would I have thought that I would be in this position, but lo and behold, here we are. So tonight I'm going to be going over the topic of pediatric pelvic physio with you guys, just kind of starting on some common conditions that may require referral to physio. We go into a little bit more in depth on those conditions, and then basically what pediatric physio entails. So I'll kind of go through the presentation, and then at the end, if you guys have any questions or you would like to discuss anything further, then we'll go ahead from there. So basically, why some children will require pediatric physiotherapy. This list is mainly the most common conditions that we see, with bedwetting being the kind of most common or number one. Overactive bladder, which means that, the kids are having to urinate more frequently. Constipation, another very, very, very common thing that we can see children for pediatric pelvic, and we'll go in through the presentation of how constipation will also tie into all the other components. Fecal incontinence, so leakage regarding stool, not urine. Recurrent urinary tract infections, and stress incontinence, also known as giggle incontinence, which is when children are engaged in an activity, or all of a sudden, somebody goes and tickles them, they laugh really, really hard, and then they unfortunately have a leak. So these are kind of some of the main things that we will see children for. We went over some common conditions. Now here are some things that parents necessarily will either have complaints about or particular concerns. One of the ones being, changing sheets is exhausting. Having to do more laundry, reduced participation in activities, so sleepovers being one of the biggest ones. And then, accidents at school are embarrassing. They're affecting confidence and self-esteem. They're wondering if their children will grow out of it. How long will they have to buy pull-ups or diapers or other forms of protection for? And it's going on for a long time, and nothing seems to be helping. And just we've tried everything. So I'll kind of start with here just by saying that we're refraining a little bit away from using the word accident, because there is a bit of a negative connotation associated with it, or just being like, oh, you're having accidents or things like that. I more or less just refer to them as leaks. And when I'm talking to children, I'll be like, okay, your bowel had a leak, or your bladder had a leak. That way, at least it takes a little bit more of the negativity away from them, meaning that their body's just, unfortunately, it's just the issue that it's having to deal with right now, and it's something that we're going to address. So when can children start pelvic physio? So awareness of bladder control and urge. So basically, the fact that you can sense that you have to go to the bathroom usually begins between 1 and 2 years of age. And in order to become fully continent, a child must be able to recognize the sense of urge, physically get to the toilet, get undressed, and then basically contract or relax their muscles in order to be able to go to the bathroom. If any of these pieces of the puzzle don't quite fit into place, then that's when we can start to run into issues. Typically, the natural age is approximately 3 to 4 years old. The treatment of constipation and daytime wetting can begin at 4 years of age, and treatment of bedwetting typically can begin at 5 years of age. That doesn't necessarily mean that if a child is younger than the age of 5, if they can't start to have pediatric pelvic physio for bedwetting. It's usually if there's if there's constipation, if they're having daytime issues as well. Oftentimes, I usually go and I address those pretty aggressively, and then we start to address bedwetting. And sometimes, even when we're addressing the daytime wetting and the constipation, then the bedwetting just naturally falls into place. So, why should pediatric pelvic health conditions be treated? Basically, there is a significant impact on emotional and physical well-being and overall quality of life for the child. So, research has shown that if children don't become continent within that 4 to 9 year old range, then they can have lasting psychological issues even into adolescence. So, depressive symptoms in about 6.8%, victimization, poor self image, and negative perceptions of school and problems with peer relationships. And unfortunately, in more extreme conditions, if pediatric pelvic health concerns go untreated, then they can lead to things like irreparable kidney damage. With need for self-catheterization and chronic megarectum, which is basically when the rectum just becomes so expanded. So bedwetting, also called nocturnal enuresis, is perhaps one of the most common things that children are referred to pediatric pelvic physio for. And essentially, what it is repeated spontaneous voiding of urine during sleep in a child 5 years or older. And basically, you can see the percentages here, but about 20% in 5 years of age, 7%, 8 years, 10%, 5% in 10 years. So as you can see that the older the child gets, the less likely this is to happen. It happens 3 times more often in boys than in girls. And basically, again, each year that goes by, there is a chance for spontaneous recovery, which means that it'll just settle on its own. But in the meantime, it can affect the child's emotional well-being, self-esteem, and social life. Social life being, sleepovers, for example, where children don't want to go to sleepovers because then they're going to have bedwetting issues. Here's just basically the different types of bedwetting. I won't go into it a lot, but monosynaptic basically means that they don't have any evidence of other issues going on with the urinary tract. No previous issues regarding bladder dysfunction. Um, then bedwetting is literally just the sole issue that they're having. The non-monosynaptic is they have recurrent lower urinary tract signs. So, they have issues during the day. They may have some, hesitancy going to the bathroom. They may be straining when they're going to the bathroom. Um, any changes in their frequency of going to the bathroom, if they're using, holding maneuvers, one of them being like the potty dance that we see with children, they cross their legs or they hold on to that area because they don't want to go. Or if it just means that they're not completely emptying their bowel or their bladder. Primary, it means that the child has never been dry overnight, which is the most common issues that we see. And then secondary, it means that bedwetting started after 6 months of dryness. So they were dry for 6 months, and then all of a sudden they started to have bedwetting issues. Some common causes for bedwetting, one of them being, infection, early sign of diabetes. It can be genetics. It's interesting that if one parent had issues with bedwetting when they were growing up, there is about a 44% chance that the child will also as well. And then that will increase to 68% if both parents have had issues with bedwetting. Urine overproduction, so whether there's something hormonal going on, if there's issues going on with how their central nervous system, so brain and spinal cord are delaying or developing, any sort of psychological stressors. So one of them, can sometimes just potty training in general can be a bit of a stressful event for a child. And sometimes there have been links shown to even just like a second sibling coming on or multiple siblings coming on. ADHD. And then I've highlighted holding patterns and constipation because those are probably the most common causes of bedwetting that we see. With constipation, it has been speculated that it's the number one cause of bedwetting, and I'll get into why that's the case in just a few slides. So how does it relate? So basically, when you have stool, that stool is starting to accumulate in the rectum. That stool can push on the bladder, so it reduces the available space. So an analogy that we can sometimes use for people who if you've had kids, right, you have a baby pushing on your bladder, so you have to pee more frequently. Stool can cause the same thing. And then if they're holding the urine, the walls of the bladder can start to thicken, and then it can lead to overactivity of the bladder. So it can cause spontaneous contraction. So that bladder is just basically starting to contract, and there's no necessarily a rhyme or a reason to it. And then they get the sense that the bladder, is only partially full, and then that leads to more frequent and stronger contractions into the bladder. So how do we treat bedwetting? The number one thing is we start with education. So sleep hygiene, making sure that kids are on a proper sleeping routine. We try to increase the amount of voids or urinations in this case throughout the day. So about 5 to 6 times a day or every 3 hours. Avoiding ingestion of fluids 2 hours before bedtime. Bladder irritants are basically foods or drinks that are known to cause irritation of the bladder and therefore cause children to have to go a little bit more frequently. So carbonated drinks, spicy food, tomato-based products, and milk are some of the big ones. Milk is shown to be basically the number one bladder irritant for kids. And then basically regular fluid intake throughout the day to dilute the urine. So basically, if we have urine sitting in the bladder, we don't want it to be at a concentrated volume, because then that can also lead to irritation of the bladder. Again, if constipation is shown to be a contributing factor, that is aggressively managed. And then biofeedback, which I'll get into a few slides. Alarm waking devices, and there is something called the dry morning program, which was developed by one of the pioneers of pediatric pelvic physiotherapy called Don Sandalchidi, and certain times medications, which is a last resort. Oftentimes, I will say that the dry morning program isn't necessarily started until we start to address all the other components. So, diet, education. If there are issues going on with the pelvic floor, we address those, and then we can get children started on a dry morning program. So here are just some devices that are sometimes seen to help manage bedwetting. The first one that we can see here, it's almost like an alarm. Where it starts to sense that urine and then an alarm goes off. Or sometimes it can be pre-programmed to even at a set time where, the child will get up and go to the bathroom, or it's a good reminder for the parents to get the child up. Again, another one being a watch, very, very similar. It's just a good reminder to get the child up throughout the middle of the night so that they're reducing the bedwetting incidences. And then here's a water bottle, because sometimes children like to chug water, and what we want to encourage is smaller, more frequent sips throughout. Here are just some considerations that are important to mention. The one is that the daytime wetting should be addressed prior to addressing the bedwetting. And like I said, oftentimes we have to try to figure out what are the causes that are causing bowel or bladder leaks throughout the day, and then we go and we address the bedwetting. Sometimes even when we address the daytime wetting, the bedwetting just naturally kind of sorts itself out. So constipation, again, it has to be treated first and aggressively. Research has shown that, actually treating the constipation is more effective than using certain types of medication. And then as well as pelvic floor muscle training, which I'll touch on a little bit more in the further slides. And sometimes even just a combination, right? So pelvic floor muscle training, any sorts of behavioral therapy, education, use of alarms or watches as needed, are shown to be actually more successful and a better course of treatment for bedwetting versus medication. And it's actually shown to have a longer term success. The next common condition that are sometimes seen in children is fecal incontinence and constipation. So fecal incontinence basically meaning that they're having like their bowel is actually leaking stool, versus urine, and constipation being that unfortunately they're having issues emptying their bowel. So fecal incontinence, also called ectopresis, So it's voluntary and involuntary passage of feces in inappropriate places in a child 4 years or older. Basically, once all organic causes are ruled out, basically meaning that there isn't something medically necessarily going on with the child. So central nervous system is intact. There aren't any sort of malformations or issues with the development of the gastrointestinal system itself, and it has to occur one time per month for around 6 months in order to be diagnosed as true fecal incontinence. And again, why does it happen? So here you can kind of see that in the diagram that a large mass of stool is accumulating in the rectum. It's starting to build, 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 build. Water gets pulled out from that stool, and it basically leaves a firm mass of stool behind. The new or the softer stool that's formed, it starts to pass that hardened mass. And basically, the internal anal sphincter is really, really sensitive and good at sensing what is trying to get past it, right? So, an example, right, is when you have to poop, right? Your body knows, that you have to hold it, get to the bathroom, and then empty. Um, Gas, similar thing, right? If you have to pass a toot and you're in an not the most appropriate situation in order to do that, then again your sphincter will contract and help prevent passing that toot. Liquid is a different story where sometimes, unfortunately, the internal anal sphincter just it lets it go. If anybody has been unfortunate enough to experience diarrhea, sometimes you just can't hold it in and you gotta go, and therefore small amounts of soft feces are left behind in the underwear, and sometimes the child doesn't even notice that this has happened until they are either getting changed or they go to the bathroom and they notice that there's stool left behind in their underwear. Again, constipation can affect up to 30% of children ages 0 to 18 worldwide. Functional, again, basically means that there's no underlying medical condition associated with it. And why is it so important? Like I mentioned, oftentimes it's the number one cause of an overactive bladder. And when constipation was resolved, then daytime wetting was also resolved in about 89% of children. And again, bedwetting also resolved in 63% of children. Also important in UTI prevention as well. Basically because if there's feces sitting in the underwear, then that can also start to get into the urinary tract and make its way up and cause an infection. So what are some therapeutic recommendations for functional constipation? Oftentimes it's education regarding fiber and fluid intake, maintaining normal levels of physical activity, and explanation and guidance for toilet training in children is another big one where sometimes people don't necessarily know the proper position to go to the bathroom in. And sometimes there is a need for fecal impaction. So either starting on laxatives or enemas are also sometimes recommended if we just can't get the constipation under control. Because, like I mentioned, the constipation oftentimes needs to be managed pretty aggressively before we can start to get into pelvic floor training and education regarding bedwetting and daytime wetting. So how can physio help with constipation? Again, a lot of education. Education is basically a very, very common theme in our role as pelvic physiotherapists treating children. And a lot of it is just, teaching children about what their body is doing. So anatomy and function of the pelvic floor, never ignoring the urge to go. So another common complaint that I hear from parents is that, kiddo is sitting in front of the TV or playing video games. They sense that they have to go to the bathroom, but they're so preoccupied with what they're doing that they basically ignore that urge. So we never want that. We never want to ignore the urge to go. When we have to go, we should go. Toileting posture and breathing patterns, and again, if any dietary changes need to be made, so increasing fiber or water. Oftentimes a home exercise program. So biofeedback I'll get into in a little bit. The whole gist of it is basically training the muscles of the pelvic floor. Manual therapy, so certain types of massage that we can do along the colon are also shown to help get things moving, and if necessary, referring to other healthcare providers for, if we need to get them on a dose of laxatives or if enemas are needed. Proper pooping posture. So squatting is better than sitting. And again, why the squatty potties are really, really nice is because they help bring us into that optimal position. Ideally, hips and knees bent at 90 degrees above the level of the hips. And then oftentimes, gentle lean forward, elbows on knees. And then sometimes kids really like to use the muscles on their inner thigh. So having their legs apart to avoid kicking those muscles in. And then maintaining breath. Belly breathing or sometimes even counting out loud is because when we are holding our breath, because there is a relationship between the diaphragm and the pelvic floor, with improper breathing, the pelvic floor just can't relax in order to help push that stool out, which is why we want to make sure that kids are breathing, and oftentimes, we get them to either count or do something else to make sure that they're doing that. And then we also have daytime voiding and storage conditions. So the kind of the other gist of this is that isn't proper coordination between the pelvic floor muscles and the bladder, and then it can lead to urinary retention, so holding of pee, and then when they go to the bathroom, that they just can't empty all the way, which also increases the risk of UTIs and other sort of kind of medical issues. And this can present as both increased and decreased frequency of urination. So oftentimes increased urination is counted as anything above 8 times a day, and decrease is anywhere under 3 times a day of a voiding pattern. And then voiding postponement, again, similar to kind of what I mentioned earlier, is they postpone going to the bathroom, and often associated with urgency. And unfortunately, over time, the more you ignore that urge to go, the bladder can lose its sensation over time. And that's never a good thing, because if your bladder loses your sense to go, then, well, unfortunately, catheterization is sometimes needed. Similar can also lead to urinary tract infections and kidney damage. Overactive bladder, again, children are going more and more and more and more and more, going throughout the night or during the day, and without any associated incontinence. So, they're not necessarily having any leaks, but they're having to go, above that at 8 times a day or under that 3 times a day. And basically, it's something to do with the activity of the muscle in the bladder. And then underactive, similar type thing, not going as frequently. So how do you treat voiding and storage conditions? So urotherapy, again, similar, regular fluid intake throughout the day. You want to be taking small sips and not chugging. Having basically a timed voiding schedule, so going anywhere between 3 to 7 times a day. Again, if constipation is a consideration, that has to be managed. And then hygiene education, so basically, teaching to wipe front to back. If clothing gets wet, then changing that. And then pelvic floor muscle training. And basically, research has shown that, pelvic floor muscle training compared to urotherapy alone did see improvements with these types of issues. So what does a physio assessment entail when somebody comes in for a pediatric pelvic session? So as far as the subjective assessment goes, So we always look for what's called red flags, right? So meaning that, things are a little bit more serious. If they do present with any sort of, pain with urination or defecation, any sort of genital or rectal pain, any sort of abnormal discharge, if they're really straining to urinate, and the combined daytime and nighttime increased frequency and incontinence, I'd say that's less of a red flag. It's a consideration for sure, but I would say it's not as serious as perhaps the ones that we see on top. We get a detailed history on when this started to happen, any sort of past medical history, We get a bladder history, so how often are they going to the bathroom? Are there, is there any need for use of pads or pull-ups? Similar with the bowel history, so the size of the stool, texture of the stool, how often are they going? Do they have any sorts of abdominal pain or gastrointestinal issues? If they have any feelings that their bladder or their bowel is just not emptying all the way, if they're having any sort of pain or bleeding, or if they're having to push really, really, really hard. We also ask about fiber intake, and if there's any bladder irritants that the child is consuming, which may be contributing. If there is any psychosocial history, so any sort of change in routines or a big kind of psychological stressor to the child's life. Sometimes we ask about family history and achievement of developmental milestones. One of them being that we know that bedwetting can be genetic if there is a genetic component to it as well. And then toilet training history. When did potty training start? Have they achieved full potty training? Yes, no. If they've noticed any sort of abnormal holding behavior, so if the child is ignoring that urge to go, are they doing that little potty dance, crossing their legs or holding on to that area just to prevent going to the bathroom? Are they taking any medications? Have there been any medical investigations done? Any sort of previous treatment? And then basically we're very goal oriented, right? So we want to know how this is impacting social life, and if there are any goals that kiddo and parents are hoping to achieve and get out of this. So if there's anybody on this chat that's been through an adult pelvic physiotherapy assessment and treatment, you'll know that there is an internal component involved with adult. There is no internal component involved with children, not at all. And oftentimes the assessment is done externally, so there is a bit of a visual component involved, if the child and the parent are comfortable. So oftentimes I ask, just the child to pull down their pants a little bit to expose their buttocks. That way we're able to see exactly what they're doing. And then for biofeedback, we just put you'll see here that's one of our biofeedback stickers, and I'll show you exactly where that's placed after. We're basically just trying to see what the activity is in that pelvic floor. Are they able to contract it? Are they able to relax it? How long does it take before they can fully relax? Or can they coordinate contraction and relaxation? Are they doing any compensatory patterns? So are they trying to, squeeze their legs together? Or are they trying to squeeze their butt really, really hard to try to make up for this? And again, some evidence behind biofeedback. We mainly use it to improve that resting tone in the pelvic floor muscles. We start to train the control of urge. So we can do it. We can target strengthening. We can target endurance, and then sometimes even just training the pelvic floor muscles, we can fatigue them to the point where they are actually able to relax. Again, here we can kind of see on this side that this machine looks exactly like the machine that we use. And again, there's no internal exam component. On this diagram here, you can see exactly where we place those electrodes. So that's kind of like that's the anus, and then we place 2 electrodes on either side, and then one just kind of as a grounding one, oftentimes on the side of their bum. And we can use that to train strength and endurance as well. So just some challenges that are associated with pelvic physio. There are some limitations as to the scope of practice. So unfortunately, as physios, we can't order any sort of imaging or any sort of medical investigation. That has to go through the family doctor. We're unable to prescribe medications, such as laxatives, or even be able to properly dose laxatives and enemas. So unfortunately, that's sometimes necessary for clean out and maintenance phases for constipation. And as physios, again, we have to get the family doctor or pediatrician involved. Patient compliance with home exercises and medication. It's hard sometimes for children and even for parents, right, to always keep an eye on this. And go through the phases of addressing this. So compliance can sometimes be an issue, and it is a relatively new field of physiotherapy. So not a lot of people know about it, which then sometimes unfortunately leads to issues with transferring knowledge. Nevertheless, it is an evolving field, and new literature, new evidence is constantly coming out, which means that as pediatric pelvic physios, we are better able to help address these issues. So, again, during all my sessions, you'll hear me frequently tell my kiddos that we're going to make them bowel and bladder bosses and help them get control of their bowel and their bladder. And if there are any questions, I'm happy to take them. Thank you for listening. I also see there's a bunch of stuff in the chat here. Awesome. Yep. Hang on, somebody's typing a question here. Oh, Allie, hi. Can't hear you.
Hi, Sarah.
Hi. How's it
Great
going?
job.
Thank you.
Nice to see you again.
Yeah, good to see you.
Couple quick questions.
Yeah.
Is there a recording of this available that we can refer to friends or clients or whatever?
Absolutely. Yeah. Emily is gonna get all of that stuff put together, and then she will, I think she's aiming to help disperse it to some groups for potentially more information on that. The meeting was recorded, so there is that.
Perfect. And do you do virtual appointments for people who are not local to Guelph?
So, I mean, there is the option. Most of the all of the kiddos that I've been seeing so far, I've seen them in person. But because there is a lot of it's all external, right? It's more or less just a visual. We can see if we can do that, or at least for the initial assessment. Oftentimes, where things may be a little bit tricky is if we want to do biofeedback. Like, obviously, unfortunately, that can't be done. That can't be done virtually. But what we can do is at least we can aim to set up like a virtual initial assessment, get an idea of what the pelvic floor is actually doing, and then if there's any need to kind of get people in, then at least if they're not local, we're having to decrease the frequency of times that they can come in.
Great, thank you.
Does that make sense?
Yep.
Yeah. So yeah, if you're inquiring about that, then oftentimes you just give Guelph Women's Health or Laura a call, and then they can help get you set up for a virtual.
Thank you.
No worries. And then we have a question here is, can you talk about incontinence while laughing, tips and tricks for kids? So again, with giggle incontinence, we have to start to figure out what exactly is the cause of it, right? Is it that constipation kind of pushing against the bladder, causing it to empty? Has the kiddo been holding their urine all throughout the day, and then all of a sudden the bladder starting to fill, and then you have something that's causing more pressure inside of the system, and then um, boom, they have giggle incontinence. Another issue that can sometimes happen is just poor training of the pelvic floor, right? The pelvic floor is confused; it doesn't know when to contract, doesn't know when to relax. Oftentimes, a good kind of visual that I use for parents and even kiddos coming into the clinic, right? The opportunity wasn't there to do it during the presentation, but again, if those are kind of like the muscles around in your pelvic floor, I'm going to use my finger as kind of like that urethra, right, where the pee is passing through. In order to be able to hold something, right, those muscles have to contract, keep it tight. Okay, that way, pelvic floor is contracting. It's helping, hold that urine, but until the child can kind of get to the bathroom, and then those muscles relax, and boom, that urine flows out. There may be an issue with just how the pelvic floor is contracting. So I'd say with giggle incontinence, there are multiple factors that come into play. those are just kind of some of the main ones. Another being just fluid intake, right? Did they chug a big water bottle before? That bladder is starting to fill until, can't hold no more, and then the cup runneth over. Does that answer your question, Leslie? Perfect. And then another question, can you share any books or resources that are meant for kids? Yeah, absolutely. So there are a ton of books out there. Steve Hodges, let me actually pop his website into the chat. He's a pediatric urologist based out in the States, and his website actually has a lot of different books and a lot of free resources for parents as well. So I'm going to pop that into the chat right now. And as well as like Dawn Sandal-Cheedy, who is, again, one of the pioneers of pelvic floor physio. Her website, Kids Bowel and Bladder, also has resources as well. Steve Hodges, pelvic floor. Okay. Awesome, no problem, my pleasure. Do you have a list of pediatric pelvic floor physio elsewhere? I'm in Owen Sound. So that's actually a good question. I don't necessarily have a list of pediatric pelvic physios, like with adult physios through Pelvic Health Solutions. There are a list of physios who do adult pelvic, but I'm not quite sure if there's a list out there for pediatric pelvic physios. That I would say, Rosalie, just an in-depth Google search looking at physiotherapy clinics in the area. I reckon to say that if there are people who do it, it would be listed on their website somewhere. So hopefully that'll help. And yeah, Owen Sound is pretty far. It's not even close enough to get you into either one of our Guelph, Laura, or Orangeville clinics. Any ideas for some good general activities of gross movement for toddlers to help develop pelvic floor muscles? So a lot of kind of like pelvic floor is part of your core, right? Oftentimes the development of those muscles does come along with development of the diaphragm. A lot of things for that to keep in mind is just trunk control, core control. Another kind of thing that we also get into a little bit during I didn't touch on a lot during the webinar, was just a bit of an orthopedic assessment, right? Just making sure that there's good lengthen through main muscles of the core. So hamstrings, glutes, things like that, all can be contributing factors. Yeah, I'd say as far as for toddlers, just kind of continuing on with a lot of the activities that are helping address their core. So making sure that they're able to keep themselves upright. If they're doing any sort of reaching or anything along the way, then they are able to actually maintain that upright position. And then keeping in mind for any sorts of, if their hamstrings are tight or any sort of muscles like that. Sometimes if you are having concerns about gross motor movement, physios can also help take a look. I do kind of like gross motor milestones and things like that, assessments on kiddos, especially if parents are having concerns. So that's certainly an option as well if you're starting to notice maybe things aren't necessarily where or things are that you're comfortable with. Does Alora have a pediatric PT too, or just Guelph? Alora does have one. That's me. So I'm based in Alora primarily. I'm there Monday to Friday, every week. But I'm at Guelph Women's Health just once a month, and that's the first Tuesday of every month. So there is the option to come and see me at either location. With being at Guelph Women's Health for such a limited time, Sometimes if I need to follow up with kiddos a little bit more frequently, I do recommend that they see me for 1 or 2 sessions on Allura, but oftentimes I try to make things as easy for you as we possibly can and getting you, as close to home as we can get you. And then, virtually before I was doing this. Yeah. So again, like Ali mentioned, virtual is a good option for people far away. We do offer that, like I said, because everything is external. We are able to get a pretty good sense of what's going on with pelvic floor. It's just, yeah, the biofeedback, and if we're starting to sense that we do want to get a session of that in to see exactly what the muscles are doing, then that would have to be arranged for. But like I said, a good option, virtual, just to kind of get things started. Thanks, Allie. So yeah, I popped open Steve Hodges' website, so bedwettingandaccidents.com, and then kidsbowellandbladder.com. So yeah, the first one's Steve Hodges, the second one is Dawn Sandal-Cheedy. And both of these websites are pretty good because they have some resources out there for more information, just some books. I think Amazon might even have some of the books, but it's nice to kind of see them before you go and you start to figure out where exactly has them. Any other questions, comments, concerns? All right. Well, if anything does come up, feel free to contact us. I have had parents in the past where they're not necessarily sure if their child is appropriate for pediatric pelvic, or if they're just having some questions. And oftentimes, if you give us a call oftentimes the best place to reach me at is Allura. Because I'm at Guelph Women's Health so infrequently, Allura is basically, where I'm stationed at the most. You can either send us an email or give us a quick call, and then front desk will help relay that information on to me. And oftentimes, I either email parents back if they've emailed me, or I can even arrange to have a quick phone call with you, just to give you a better idea of what to expect. Would this be appropriate? And things like that. So if you need anything from that perspective, please feel free to reach out. Mm, Are there any kids pads you have recommended versus pull-ups? Pads as in like, oh, I see. So I mean, there are ones that I don't think there's one specifically made for kids, unfortunately. Sometimes it's even just like the adult ones can sometimes, like the liners are ones that can sometimes be used. That's a good question. Yeah, I'll have to do a little bit of digging on that one. Yeah, you got it. Something that allows them to wear underwear. Yeah. So like I said, oftentimes it's just, I think, always discreet, or just like the panty liners that they can just kind of slide in underwear. For males, it's a little bit more challenging, if they're not quite used to having something in that area, but they do help. Anything else? Awesome. Would it be helpful if I put the both clinics, like the clinic information, into the chat, or are you guys pretty okay with helping find that online? Just in case you do need to get in touch with me. I can do it regardless. My pleasure. Hopefully that was helpful. I tried to get kind of through everything as best as I could. But yeah, hopefully that was informative enough for you guys. Like it, no problem. My pleasure. Yeah, I'm gonna pop in the chat or like the website for Alora and Gulf Women's Health. On that, we have a little bit more information regarding pediatric pelvic as well. No problem. Thank you guys for joining me. So that's Gulf Women's Health, and then I'll pop up Alora as well. And yeah, like I said, if you do have any comments or concerns, or if you want to have a chat with me, please feel free to reach out. You might not be able to kind of get me directly, but if you send us an email or give us a call, and if you're okay with it, just kind of leaving your contact information, then I can aim to get in touch with you when I'm available. No problem. My pleasure. Thank you. All right. Well, thank you again for joining me. I know you guys all have busy lives and kiddos to take care of, so thanks again. And yeah, if you need anything, just please let us know, and we'll go from there. I can also hang out for another like minute or two, just in case anybody has any. Just until everybody is left to make sure that nobody has any questions. Thanks, Emily.
No problem.
How's the recording gonna work, or like things like that?
So the recording I can send out with a link, and I was hoping to possibly put on our website, but that will take a little longer since I will be sensitive with people's names, so I'll kind of blur that information out, and probably will end up on YouTube again. Everything will be blurred out, any personal information.
Awesome. Sounds good. Yeah, because I think people were yeah. No problem. Yep. So
yeah,
be on
of course.
for that, Laura. Yeah. So a couple people saying that they missed it and they would like it.
Yeah, absolutely. I can send that out. I have the email list, so I'll follow up with all the participants in the email list, and then yeah, get everyone connected.
Awesome. Sounds good. Alrighty. Well, good time to sign off.
Yeah, very well done, Sarah.
Thanks.
Have a good night.
Yeah, you too. Thank you. Bye, everyone.
Bye.